Hello and welcome to today's lecture on small for gestational age infant case study and clinical reflection. In this session, I'll be analyzing a clinical case of an SGA infant, exploring potential causes, diagnostic clues, and the implications of asymmetric growth patterns. Let's get started. Let's begin with the case. A woman, Gravida 2, Para 1, presented in early full-term labor after her membranes ruptured an hour earlier. Her last ultrasound at 20 weeks showed a normal female fetus with abdominal circumference and biparietal diameters at the 40th percentile. Both parents were small for gestational age. After 20 weeks, she moved to rural Bangladesh and received no further prenatal care. A female infant was delivered vaginally without complications, with APGAR scores of 8 and 9. The birth weight and abdominal circumference were below the 5th percentile, while biparietal diameter and body length were normal. The Ballard score was 37, confirming full-term status. To guide our analysis, let's reflect on these questions. Would this neonate be considered constitutionally small for gestational age? What factors could have altered normal fetal growth? What are the likely causes given a normal 20-week ultrasound? What implications does an asymmetric growth pattern carry? How does the Ballard score impact our diagnosis? What maternal history details are important? Could this neonate be constitutionally small for gestational age? It's possible given that both parents were born SGA, indicating a genetic predisposition. The asymmetric growth pattern with normal head size but low birth weight and abdominal circumference suggests constitutional smallness rather than symmetrical growth restriction. However, we should also consider intrauterine growth restriction due to environmental or placental factors. Several factors could have influenced fetal growth. Maternal environment and nutrition. Living in rural Bangladesh may have affected nutritional intake. Lack of prenatal care. No monitoring after 20 weeks could have missed placental insufficiency. Infections, exposure to endemic infections like malaria. Genetic factors. Family history of SGA births suggests genetic predisposition. Environmental stressors, stress or illness during pregnancy could impact fetal growth. Considering the normal 20-week ultrasound, the most likely contributors to the asymmetric growth pattern are placental insufficiency leading to a brain-sparing effect, nutritional deficiency due to possible dietary changes in Bangladesh, environmental stressors, maternal stress or infections, genetic predisposition. Given the family history of SGA births, asymmetric growth patterns typically indicate uteroplacental insufficiency. This leads to brain-sparing effect, preserving head circumference while abdominal growth is restricted, increased risks of hypoglycemia, hypothermia, and developmental delays. These infants often exhibit catch-up growth if provided with adequate postnatal nutrition and care. The Ballard score assesses neuromuscular and physical maturity, estimating gestational age. In this case, a score of 37 weeks confirms full-term status, supporting the diagnosis of SGA rather than prematurity. This rules out preterm birth as a cause of low birth weight, highlighting potential IUGR or constitutional SGA. To summarize, the infant demonstrates asymmetric growth likely due to placental insufficiency or nutritional deficiencies, compounded by genetic predisposition. Postnatal monitoring for hypoglycemia and hypothermia is essential. Nutritional support is crucial for catch-up growth. Long-term follow-up is recommended to monitor developmental milestones and growth. Thank you for joining today's lecture. Understanding the complexities of SGA infants is essential for optimal neonatal care. Don't forget to subscribe for more clinical insights.